think Dr. Rohita has explained it very well. Now we move on to our next talk by Dr. Aishwarya. She'll be talking about how we plan toric and an IOL calculation in post-refractive surgeries. Dr. Aishwarya.
Thank you. Good afternoon, everyone. Today I'll be talking about patients who come with refractive surgery done, and you think that it is a usual formula that you can use for IOL power calculation, but it is, and you do a beautiful surgery, but eventually you decide that, oh, patient is unhappy because there is a refractive surprise. So the lesson number one is that basics don't change for post-refractive surgery eyes, but every eye is unique. Once we keep that in mind, we have to remember that in post-RK eyes, like Dr. Rohita mentioned, that the ratio of the posterior to anterior corneal radii is greater in the central zone and smaller in the paracentral zone. You have an irregular cornea to start with, and there is going to be diurnal fluctuation which occurs as a result of hypoxia from lid closure, leading to edema, leading to hyperopic shift when the patient wakes up. So eventually the early morning scans are going to be better. In post-LASIK eyes, you have to first of all decide what kind of LASIK was done. Was it myopic LASIK? Was it hyperopic LASIK? Was it presbyl LASIK? Or it is a decentered ablation that you are dealing with. Having said this, think about post-SMILE eyes. Right now, you may not be getting a lot of patients, but as of now, the studies which are available, in 2015, one study came out which said that post-operative higher order aberrations were much lower after SMILE as compared to LASIK, and after SMILE, the sagittal curvature were constant for the central 4 mm diameter in contrast to LASIK, and featured over a 5 mm zone on the total cornea. FS LASIK induced more coma, higher aberration of around 0.13 as compared to SMILE. With this thing, lesson number 2, the pre-operative workup is quite essential. You have to look at the slit lamp fundus examination, the number of RK cuts, how is the LASIK flap, how many corneal opacities, is there any NVI, is there any ZD, is there any phacodonosis, look for black and hypermature cataracts, look for dilated fundus examination, any diabetic retinopathy, any vitreous hemorrhage, any retinal detachment, all need to be catered to. With that, like Dr. Naren mentioned about dry eye evaluation, in our setup, we do a thorough evaluation which comes from symptoms, the Schirmer strips, the T-BUT, the OSTI score. Once it is noted down, the treatment is given and the resolution happens. The epithelial mapping, meibography, Schirmer's test and T-BUT all are noted down. The therapy is tablet doxy along with some steroids, along with sodium hyaluronate eye drops with cyclosporin eye drops. The treatment is for 1 month, and after that you get better regularized corneas. Now, coming to the corneal topography scans, we have already spoken about the EKR map and the refractive 4 map, so I'll not go details into that. We have to remember one thing, that how the EKR map has to look. If only by visual assessment you have to see that if a good EKR map has to look something like a peak with a narrow base, and if you have a bad EKR map, you have multiple peaks and broad base or both. Please remember that for both myopic and hyperopic LASIK, 4.5 mm zone has high correlation with the central corneal power. With decentered ablation, if you have a patient like that, the typical case presentation will have a decentered ablation zone along with increased higher ablation, along with a tail on point spread function with reduced best BCVA that improves only with gas permeable lenses, along with a cylindrical measurement on auto-refraction and wavefront that differs from manifest refraction. Also a history of reduced vision immediately after surgery that fails to improve with time. That is what you will get. Now, the corneal meridian connecting the ablation zone central to pupil center is the most affected, as it lies in the transition zone between the maximal to the minimal dioptric powers. With this in mind, what we believe is that we have to treat the irregular cornea or the decentered ablation and do also incomplete ablation if it is present. Excimer laser, do the ablation, regularize the cornea. It improves the central corneal symmetry, but it does not correct refractive error. So conventionally, we know that IOL can be inserted after secondary LASIK or surface ablation. We can have an altered mean K value, but this will result in unpredictable shift in refraction. Today we do TCAT. Now, TCAT is basically like, if you have a decentered ablation, patient is already having astigmatism, glare and halos. Without treatment, you give even a monofocal IOL, patient is going to be super unhappy. What you do is you give a trial of RGP contact lenses, see if there is no improvement, go for monofocal IOLs. But if you see that there is improvement in visual quality, if you see that corneal regularization will benefit, do a TCAT, do IOL power calculation, and then you can even go for a multifocal diffractive IOL implantation with this. Our protocol has been corneal customization before cataract surgery, and we've published 2 beautiful papers regarding the same. Lesson number 3. Post-refractive surgery, the corneas which have issues which influence the IOL power calculations and outcomes. Post-RK corneas, I have already mentioned this, that irregular astigmatism with smaller optical zones will be present, with high length, axial length, and often pre-RK history will not be available. It is said that RK is a gift which keeps on giving. The hyperopia will keep on coming. Post-LASIK corneas will have 3 kinds of errors. Instrument error, where there will be an error in axial length measurement. There will be keratometers which will measure paracentral points at 3.2 millimeter. But in post-myopic eyes, we can miss the central flatter zone, overestimating the corneal power and hence an hyperoptic shift. You can have a refractive index error, ma'am has already mentioned that, and you can have a formula error. Here, 1 millimeter error in effective lens position can cause 1.5 diopter change in final diffraction. Lesson number 4. Post-RK and post-LASIK eyes need individualized IOL calculations. You have multiple formulas, Barrett True K history, with partial history, with no history, with double K Holiday, Potwin Hill, Haggis formula, the online calculators, ASCRS power calculators. All these formulas have been proven. For example, in this particular study, which said that it is preferable to use the True K history or the True K partial history formula, but good results are obtained in eyes where no refractive history is available by either using the True K no history or Haggis formula as well. This approach, that is like you are having this formulas in a single machine, the biometric data from multiple devices are not required. It is a very big plus point here. And also, here the post-RK refraction is very important, which has to be taken in the most hyperopic refraction on record for a particular eye, which I mentioned has to be early in the morning. And the inclusion of pre-RK data provides a small additional benefit, but it is not essential. This we've already talked about the ASCRS calculator, and I'll not go into the details of this. Here we have to talk about the prior RK, that is the target refraction. Since this is a eye which will go into hyperopia later on also, 8-cut RK, you have to aim for -1, with 12-cut RK -1.5, 16-cut RK -2, and so on and so forth. We can enter the values of EKR holiday map or the Atlas ring values, which is actually the correct method over here. But you can also go for the A constant, which is the planned IOL. So now, is there a difference between 2RK and 2K LASIK PRK? Yes, it is different because it is employed for myopic or hyperopic LASIK, as while the normal relationship between the anterior and posterior cornea is altered by RK, the change is less fundamental than that which occurs after laser vision correction. Coming to options of IOL power calculations post-LASIK, plethora of, a lot of hard work has gone into these formulas. I'll talk a little bit about the Haggis-L formula. In Haggis-L formula, we have 2 versions. One is the Haggis-L and Haggis-L hyperopic version. The only difference between the two is the hyperopic version of Haggis-L first calculates a new corneal radius based on the myopic Haggis-L algorithm. Now, Haggis-L formula corrects the IOL value of corneal radius. You can go to effective equivalent corneal power is taken, subtract 0.35 to allow for ELP prediction error, reconvert into effective radius of RI of 1.3315 and enter in the regular Haggis formula. This formula has also been known to be accurate for predicting IOL power in Asian patients who had previous myopic LASIK PRK with little variation and accuracy. So these are the EKR values that we have entered in the central Atlas ring values, and all the other formulas which have been used are entered over here. This is the hyperopic LASIK PRK formula. But you can see that these calculators are having multi-formula approach. We can go to Barrett True K formula, which we have already spoken about, and TK is very beneficial because it does not rely on assumptions on the posterior surface, but is a measurement of total corneal power, taking actual posterior corneal curvatures into consideration. Now with this TK, we have three formulas, that is Barrett TK Universal 2, Barrett TK Toric, and Barrett 2K with TK. But do you think that only one machine has this? No. We have all other SSOCT biometers which are new in our armamentarium, and this is Lenstar, iStar 900, ILMaster 700, anterior and Argos biometer, which also deal with Barrett 2K formulas as well. Barrett 2K formula for prior myopic or hyperopic LASIK, this is the formula which we can use from online, and we also have the 2K toric calculator. Coming to lesson number 5, selection of IOLs needs chair time. Now patient needs counseling. We have to see what kind of work they do, what kind of a personality they have, and we have to counsel about the procedure, the risk benefits, and the neuroadaptation, and also take informed consent. We have to also understand how much they are willing to use glasses or not. Now trifocals in post-myopic LASIK, when to do and when not to do. We have to think about the realistic expectations versus the unrealistic expectations. Angle alpha is very important. It has to be less than 0.5 if you want to implant a trifocal. HOA, again, less than 0.5. Has to have a normal retina. And like we have mentioned, dry eye needs to be treated. And if there is an irregular corneal surface, the TCAT regularization should be done. With this in mind, higher order aberrations, which IOL would you prefer? You can go for a bifocal diffractive, that is Restore, Alcon, or Technis diffractive multifocal IOL, or you can go for a diffractive trifocal IOLs, for example, Alcon Panoptics, Technis Synergy OptiBlue, and AT Lisa Tri. If you have, of course, higher order aberrations which are more than 0.5 and coma is more than 0.35, going for monofocal and toric monofocal makes sense. Angle alpha also holds a very special place. Angle alpha is something where one of the papers mentioned that for patients with 0.4 mm or higher in angle alpha, the choice to implant a EDOF lens would be carefully considered. And EDOF lens are closest to this particular range, that is around 0.3 to 0.4, because they give high quality of vision. They have minimum visual symptoms in low light, and these patients will get a continuous range of good vision through intermediate and near. Contrast sensitivity, of course, if it is a good contrast sensitivity, we would like to go for a diffractive IOL as compared to if it is a poor one, you can go for EDOF and monofocal ones. And coming to pupil size. Now pupil size is extremely important because, like this paper suggests, that post-operative pupil size correlates with contrast in diffractive IOL implanted eyes. Eyes with a pre-operative pupil size of 3 mm or less had worse contrast sensitivity than those with a pre-operative pupil size greater than 3. But when these small pupils after surgery became larger, then the contrast sensitivity improved and was no longer significantly different from the larger pupil size. This is the formula that we have been using, that IOL selection in post-refractive eyes. We have the myopic LASIK if it was there, and if you have more positive SA, you would like to implant a negative spherical IOL. And if it was a more negative SA in hyperopic LASIK, implant a positive spherical IOL, positive spherical aberration IOL, and go for radial keratopathy is present, then determine what kind of SA is present and accordingly implant the IOLs. Now lesson number 6. These are special cases and they have to have special intraoperative and postoperative commitments. We have to avoid the intersection of the main entry, and 2.2 or 2.24 incision can be preferred, and clear corneal incisions can be placed peripherally between the two adjacent arcade incisions. Stabilizing sutures can be used. Scleral tunnel or scleral incisions can be done, and we have to remember to guard the LASIK flap during the surgery if there is a LASIK flap involved. And the lowering of IOP has to happen during the surgery. It should not be very high, or it should not be too low also. And avoid high pressures during hydrodissection, and we have to monitor bottle height. In the phacoemulsification part, when it comes to post-LASIK eyes, guarding the LASIK flap is actually one of the most important things that we should do. And also sudden deepening of anterior chamber may cause discomfort to the patient. Intracameral lignocaine is helpful with the lifting of iris with cannula in these cases. Surgical pulse, of course, the central CCC is very important with a good cataract surgery. You can implant a capsular tension ring along with, so that you can have stability of bag, and centration of IOL is very important because as we know that if there is a decentered rhexis, there can be tilting of IOL leading to dysphotopsia and visual acuity. So words of caution, realistic expectations, quality of vision to be explained, longer period of stabilization, fluctuation of vision may happen, and there can be greater chance of RK incision splitting open at the time of a surgery or towards the end of the procedure. Sutures and fibrin glue may be required during this thing, during the surgery. And if you have a post-LASIK patient cataract surgery, again, glasses, we need to discuss that. We have to remember the long axial length posterior segment retinal changes. If there are any HOAs, we have to remember what we have to tell about the patient that why we are going for a particular IOL. We can talk about enhancement secondary IOL implantation if that thing exists. If monovision was done for LASIK, then we have to explain which vision will be expected now, and of course look for the retropulsion syndrome and avoid sudden decompression of the anterior chamber. For post-smile eyes, all these things remain the same except for the fact that maybe ray tracing calculations have been found to be probably better in these cases. I'll talk about this in the recent studies. Now, recent studies, we have found that Holiday 2 formula have performed well, Barrett 2K formula have performed well. And in this particular study, where total keratometry in IOL power calculations with previous lens refractive surgery was done, it was found that posterior corneal values and post-laser that in the accuracy of these IOL calculations in post-laser eyes can be improved by addition of the posterior corneal values. These are the scans which, these are the records which show that Barrett 2K TK actually performed quite well for both post-hyperopic and post-myopic LASIK. Some studies have also shown that if you have post-RK eyes with pre-RK refraction, then Barrett 2K history formula is better. If you have no refraction present, then going for no history formula of Barrett 2K or Haigis formula or OCT based or ASCRS calculated average all works better than Potwin Hill, SRKT, Hoffer-Q and Holiday formulas. If people say that in post-smile eyes we cannot implant multifocal IOLs, then a study was published where a trifocal multifocal IOL of 80 LISA was implanted and patient was pretty happy with the result. So I think it is all about choosing the right patient for these cases. In post-smile eyes, theoretical models have been discussed earlier, and even they have discussed that clinical history, if you don't have it, then you can go for Potwin Hill and Barrett 2K. But if you have clinical history present, then Barrett 2K formula with Masket formula can also work well for the patients. This particular study is a real life study where total 11 eyes of 7 patients were included after mean follow-up of smile of 2 plus 1 month and a mean follow-up after cataract surgery of around 8 plus minus 11 months. And they found that physical ray tracing should be employed for IOL power calculation. Here they use the Oculix software for doing the physical ray tracing, and they found that this was better as compared to the formulas which were Potwin Hill and Masket, but they should be ideally compared and then decided what we have to do. Now coming to the last lesson, which is about real life scenarios, I'll talk about a post-LASIK patient. This was a 46-year-old gentleman who came with both eyes myopic LASIK done in 2012. The right eye was having vision of UDVA 618 and left eye 618 again. BC was 6/9 and 615. Both eyes had nucleus crisis grade 2. Here the higher order aberrations was slightly on the higher side, 0.6 in the right eye, and also the EKR map showed a decent point curve over here. But this was in the left eye also the higher order aberrations were 1.39. So it was decided not to go for a trifocal or a multifocal lens, but we decided to go for a Vivity lens. Now in Vivity lens we did both the scans, that is the IOL master scan and the lens star scan. In the right eye, we found that it was around 17.5 is what we were getting with Barrett TK2K formula using the IOL master. And in the left eye, we got 17.5. Similarly, in the lens star, we got that in the right eye was plus 18 and in the left eye it was close to 18.5 in the left eye. Now let's see what the surgeon did. Surgeon implanted right eye Vivity plus 18 and left eye 18.5. Now Barrett 2K no history formula had suggested something like 17.78 for the right eye and 18.15 for the left eye. So you can see that the difference between these three formulas, be it the previous one these two and the next two are very, very close by. But what is actually giving 6 by 6 is probably something which is closer to the formulas which are closer to Barrett TK True K. And as compared to that, in the left eye, when the slightly higher power IOL was added, plus 18.5, we got a minus 0.75 diopter spherical as residual. So probably this explains what we have been talking till now, how small little changes can make a difference to the patient's vision. So take-home message for this talk is that post-LVC cataract, chair time and history taking is essential. We have to decide which formula which will work depending on the machines that you have. Barrett True K has given good results in post-LVC eyes, and AISHWARYA calculators are also equally good for many formulae to choose and compare from, and they work well. Surgical expertise with IOL choice is very important, and exciting studies are still going on, and we are still learning every day. Thank you so much.
Thank you, Dr. Aishwarya. So I think like she mentioned, see, in terms of decision of IOLs in these kind of post-refractive eyes, do not shy away from non-diffractive EDOF IOLs. They do really well, including a trifocal also. Okay, if you're planning a trifocal, your inclusion criteria is the same. I'm sure you've seen one slide where she showed, you know, how much the higher aberration should be, how much the angle alpha should be, and so on and so forth. There are full inclusion criteria for a trifocal was given, right? Trifocal, or you can use a term called as a diffractive presbyopic lens. Anything which is a diffractive, you have to follow the criteria what she had mentioned. If by chance if it is not suiting that criteria, then you can go with a non-diffractive presbyopic lens. The industry is completely confused, not just the doctors, including patients, everybody. Like, with the EDOF, diffractive EDOF, non-diffractive EDOF, then you have enhanced monofocal. So I think just to make it very, very simple, you have a diffractive presbyopic lens and a non-diffractive presbyopic lens, period. That's it. There are only two kinds of presbyopic lens. Keep that in mind. And then the counseling becomes easier, your workup, selection, everything becomes so much more easier, okay? And always remember, do not shy away if the patient is affordable and willing. Do not shy away from regularizing the cornea before you do the treatment. The outcomes is the quality of vision, what you're delivering to the patient, even if you're doing a monofocal, is really good. Like the previous speaker, Dr. Rohit also was telling about the keratoconic eyes. What is very, very important is when it comes, just have a look if the cone is centered or decentered. Okay, so if it is a decentered cone, just by putting rings, you can bring it to the center. That way, not just your monofocal IOLs, even your toric calculation and accuracy significantly goes up. And it becomes so much more easier. Okay, just keep these points in mind.